All right, let's dive right in. Today, we're tackling infectious keratitis, a serious ophthalmological challenge where every second counts. Think of it as a microbial detective story, where getting the diagnosis right and acting fast is absolutely critical to preserving a person's sight.
So here's our game plan for today. We're going to follow this case from start to finish. We'll begin at the crime scene, the initial presentation. Then we'll move into the forensics of identifying our culprits. We'll profile them, talk strategy with targeted treatment protocols, look at some special cases, and finally, face the consequences of what happens when a case goes unsolved.
So, first things first, let's get to the scene of the crime and properly define the condition at the very center of our investigation: keratitis. Now, keratitis is way more than just a simple inflammation. It's a full-on assault on the cornea that demands a swift and decisive response. If you don't get it right, you're looking at severe, often permanent damage to the eye. And the list of potential culprits is long. We're talking bacteria, viruses, fungi, even protozoa, which makes nailing down the exact cause absolutely essential. The crime scene itself often gives us our first big clues. If a patient comes in with a history of getting poked in the eye with, say, a tree branch, and you see these feathery-edged infiltrates, your alarm bells for fungal keratitis should be ringing loud and clear. On the other hand, if you see that classic branching, tree-like pattern, the dendriform defect, well, that's practically a calling card for a herpetic virus. Okay, so we've got our initial suspicions based on the clinical picture. Now it's time to bring in the forensic team. Let's look at the actual diagnostic tools we use to get a definitive ID on our microbial villain. And here is our core diagnostic toolkit. This is so important. You have to get your samples, whether it's a corneal scraping for culture, a swab for a NAAT, or a sample for a KOH prep, before you even think about starting antimicrobial therapy. It's non-negotiable. Otherwise, you risk masking the pathogen, which could lead you down the completely wrong treatment path. So, with our diagnostic methods locked down, we can start to assemble our rogues gallery. Let's get to know the primary suspects we're most likely to run into in these cases. In the bacterial world, you've got a pretty diverse lineup. You have your frequent flyers, like Pseudomonas and Staph aureus, along with a host of other gram-positives and negatives. And pay close attention to this. There's a very specific link between contact lens wear and culprits like Bacillus and Serratia. That's a key piece of patient history. Now, when it comes to viral keratitis, the case is pretty much dominated by one major player. Herpes Simplex Virus type 1, or HSV1, is responsible for the vast majority of infections. Yeah, you'll see others like VZV or CMV pop up now and then, but they are much, much less common. But here's the catch with HSV1. Drug resistance is a real and growing concern. About 6% of immunocompetent patients will develop resistance to acyclovir. Clinically, you should start suspecting this if you have an epithelial lesion that just refuses to heal after 3 weeks of what should be appropriate therapy. And rounding out our gallery, we have the fungi, like Aspergillus and Fusarium. And then there's the really formidable protozoan, Acanthamoeba. This one is a real problem child, primarily affecting contact lens wearers and being notoriously tough to treat because it forms these highly resistant cysts. Okay, let's put this into practice. Quick case file for you. A patient comes in, they have those distinct feathery-edged infiltrates, and they tell you they got some plant matter in their eye a few days ago. Based on just that evidence, who's your prime suspect? Exactly. The clinical picture is practically textbook for fungal keratitis. The history and the clinical signs point directly to a fungal cause. This means throwing standard antibiotics at it would be completely useless. You need specific antifungal therapy right from the get-go. And, before we arm ourselves with all these complex treatment protocols, just a quick moment of levity here. Why did the microbial pathogen cross the cornea? To get to the other side, where it caused more inflammation, of course. All right, now that we've properly identified our culprits, let's talk about deploying the right therapeutic weapons from our arsenal. It's all about selecting the right tool for the job to neutralize these threats. For bacterial keratitis, particularly from an aggressive bug like Pseudomonas, your first line of attack is topical antibiotic therapy. But here is the absolute golden rule. Do not add corticosteroids during the initial phase.
I can't stress this enough. It can seriously worsen the infection.
Now, treating HSV is a bit more nuanced. It really depends on the presentation. If it's a simple epithelial disease, you'll manage it with topical acyclovir. To prevent it from coming back, you'd use oral valacyclovir. And this is key. In cases of immune stromal keratitis, you have to use corticosteroids, but they must be paired with antiviral therapy to control the inflammation without letting the virus run wild. And what about our most resilient bad guys? Well, they require highly specialized treatment. Fungal infections need heavy hitters like natamycin or voriconazole. Acinpamuiba demands a combination of therapies, and corticosteroids are strictly off limits until at least 2 weeks of anti-amobit treatment is complete.
Okay, let's shift gears now and talk about some special populations, specifically our pediatric patients, and then get into the all-important strategies for prevention and control. In newborns, treating conjunctivitis is all about stopping it from escalating to keratitis. For infections passed during birth, like gonorrhea or chlamydia, you have to think systemically. Oral or IV therapy is required. For other bacterial causes, you can typically manage them with topical agents.
When it comes to prevention, so much of it hinges on patient behavior. Meticulous hygiene with contact lenses and just good old-fashioned hand washing are absolutely non-negotiable. Control, on the other hand, can become a public health matter, like advising partner notification when the keratitis is tied to an STI. And that brings us to our final section, the aftermath. This is where we look at the severe and sometimes truly devastating consequences that can happen if a case of infectious keratitis isn't handled correctly and quickly. The stakes here are incredibly high. We're talking about complications ranging from corneal scarring and permanent vision loss all the way to corneal perforation, which can happen alarmingly fast with gonococcal keratitis. The infection can even spread systemically. And with HSV, you have the added long-term risks of chronic inflammation and true emergencies like acute retinal necrosis. It just underscores how critical a swift, precise investigation really is. So, we'll leave you with this final, critical question. The microbial world isn't standing still. As these pathogens evolve and as drug resistance continues to climb, our own clinical detective strategies have to adapt and evolve right alongside them. This ongoing investigation to protect the irreplaceable gift of sight is a challenge that truly demands our very best.